Listen to all of Weill Cornell Medicine's informative podcasts at weillcornell.org/podcasts.
Welcome to Weill Cornell Medicine CancerCast, conversations about new developments in medicine, cancer care, and research. I'm your host, Dr. John Leonard, and today our topic is new developments in myeloma therapy. I'm very happy today to have as our guest my colleague, Dr. Adriana Rossi, a hematologist and medical oncologist and Associate Director of the Myeloma Center at Weill Cornell Medicine and NewYork-Presbyterian Hospital. Dr. Rossi works to develop clinical and translational research projects focused on patients with relapsed and refractory myeloma, especially around the areas of evaluation of the microenvironment of myeloma cells and the measurement of minimal residual disease. She also has a particular interest in the effects of plasma cell disorders on the kidney. So, Dr. Rossi, thank you so much for being here today. It's really great to have you join us on CancerCast.
Thank you so much for having me.
For those in the audience who are less connected to myeloma, just give us a minute or two on kind of what is myeloma and how do patients present with myeloma and kind of what's the typical course historically before we get to what's new.
Absolutely. It is definitely a very changing field. Myeloma is considered a blood cancer, and just like leukemia, lymphoma, it really resides in the bone marrow. So that's one area of confusion. And as such, it tends to cause direct damage to the bones. And as plasma cells, which are the cells that become cancerous in myeloma, are little factories of antibodies, these antibodies float around the blood and can be toxic to kidneys. So it is a blood disorder, but usually patients will notice some kind of issue with either the kidneys or the bones that will bring them to medical attention. And in working those up, we identify the myeloma. It is definitely not something you find if you're not looking for it. So I think one of the big advances has been educating physicians so that neurologists and nephrologists and other specialists now know to look for it. And so we are finding it sooner rather than, after there's significant damage. We're also finding it in primary care and screening for surgery. There's some abnormal lab. The primary care is following up and finding them early. So we now have a significant number of patients who come to medical attention just because, they'll come to my clinic and say, my doctor told me to come. I don't really know why. But some of them are because of, as I mentioned, kidney bones, sometimes nerve damage, sometimes fatigue, and very nonspecific symptoms that end up being attributed to anemia and other symptoms.
So like leukemias in particular, and to some extent lymphomas, which also involve the lymph nodes, myeloma cells reside in the bone marrow, but yet they have all of these effects on the kidneys, the nerves sometimes, and the bones. So why do, and they're all different situations, but maybe in a nutshell, why do the cells that live in the bone marrow, the cavity inside the bone, either have longer distance effects on these other areas?
So they live, as you said, the marrow is inside the bone. And this is, I think you mentioned the microenvironment. That is sort of all the other cells that live in the bone marrow. So a lot of the original focus had been on myeloma cells and studying the cells, which are very difficult to isolate. While we can't seem to make them go away in patients, the minute you do a biopsy or extract them to study them in a test tube, they die off. And so they're very dependent on their neighborhood, and they affect the neighborhood. So in a patient with myeloma, even if they've been in remission where you can't find the myeloma for 10 years, the other components, such as the T cells and B cells and the blood vessels and the bone cells, are all abnormal. So they never really revert back to the same as a patient who's never had myeloma. And one of the effects is the bones. So bones are constantly being made and broken down, and the myeloma cells send a signal, say, just go ahead and break, don't bother making again. So that's where the bone damage comes from. And since they are making antibodies at all times, antibodies a protein that gets put into the blood, and they mostly tend to clog up the kidneys. As if you think of the kidneys as a filtration system, these little proteins sort of get sticky and prevent them from getting the job done. So that's mostly of those. And the antibodies can also misfold in something called amyloid. And in that instance, they can stick anywhere. Most likely it's the kidneys and the heart, but the GI tract or the nerves are also common targets.
Great. So before we get to some of the newer treatments, I mean, chemotherapy has been a standard treatment for myeloma for many years, I guess going back to the 60s and 70s. And then as a follow-on to that, higher doses of chemotherapy and stem cell transplant became standard. And it seemed like those kind of made progress, made a difference for some people, but that was limited. Why is it that chemotherapy kind of only goes so far? And obviously I think a lot of the focus has been moving on from there in myeloma.
Absolutely. So just to give a little historic background, we started using melphalan in the 1958, 1962. We started upping the dose, and we learned that the more you use, the more myeloma you kill. But at a certain point, you start taking down too many other things. It is a fairly nonspecific chemotherapy. In the 80s, when we learned how to use stem cells, it allowed us to use such high doses that we could rescue with stem cells, and we call that an autologous transplant. And it wasn't until the 1980s, that we were able to get a complete remission. And so a lot of the excitement over transplant comes from the fact that up till that day, we never got our patients into remission. Myeloma was entirely palliative. We would radiate them and treat their pain, and that was about it. With transplants, we would get a few patients in a complete remission, and that was exciting. And what has revolutionized the field is that after the turn of the century, some of these novel drugs can get you into a complete remission without having to go through the toxicity of a transplant. So it's one of the great debates in the field is now how to position the many, many options that we have. Mm-hmm. Chemotherapy, such as melphalan, which is the drug that we use, is nonspecific and just attacks all dividing cells. And myeloma is just a very worthy opponent who kind of gets smart to anything we do. The standard of therapy, I would say now for a newly diagnosed patient, is a 3-drug regimen because you're hitting it from multiple angles, and that seems to give us better success. The whole idea of using a single agent, even if it's melphalan and even if it's in high doses, sort of puts an evolutionary pressure on the cells that they will then overcome. I certainly have patients in my clinic who got transplants back in the 90s and are still with us. And this was before we implemented the concept of maintenance that is now fairly well established. So they had a transplant, and 20 years later, they're still myeloma free. And one of the things that I am most excited about is trying to learn more about, again, the disease of the microenvironment. There is something about those patients that is inherently different from another one who relapses 6 months into their therapy. And learning about the different myelomas. There are certainly, I would say, about 7 different subtypes that are clinically distinct, right? The ones that are mostly renally affected, the ones that keep relapsing, the ones who get into an MGUS-like state but never relapse and never have end organ damage, and the other ones that manage to get into a MRD negative CR but not stay in it. So in retrospect, you can go back and see, but it would be really nice to have the tools to identify them up front and be able to design a therapy that is most effective for that patient.
So before we get to some of the kind of the next generation of treatments after chemotherapy, you alluded to the 7, if I had that right, 7 different types, more or less. And how are these classified? Are they kind of presumptive clinical definitions? Are they genetic definitions? Are these things that someone diagnosed with myeloma would have their doctor send off a test? Kind of where does that stand in the subclassification of myeloma today in practice?
Yeah, so right now I would say in my mind, it does not exist, right? We have an increasing number of tools. At first, it was FISH with the cytogenetics, has a risk stratification. We do have a staging system that now incorporates cytogenetics. For a while, certain centers were using gene expression profiling. So there are different tools that come up, seem to distinguish risk, and now we use them. I think it's a multivariate analysis that the clinician does, but it mostly comes down to clinical experience. So physicians who work at myeloma centers, in conferences, in conversation, in our anecdotes, we all recognize, we all have these patients, and we know it's a handful. So I chose 7. But it's not something that we can test for. It's not something that fits into boxes yet. But I fully expect that in the next decade or so, we would be able to do that. As you know, there are 60 lymphomas,
Sure.
but that doesn't necessarily change their management.
Right.
Myeloma is considered one disease, and yet there are patients that need to be managed very, very differently.
So following chemotherapy, and it seems like the 2 next kind of classes of drugs or type of drugs were the proteasome inhibitors, bortezomib or Velcade being one of those, and then the immunomodulatory drugs or thalidomide and lenalidomide. And so kind of how did those change things for myeloma patients in the big picture? And I know they're now combinations, and those combinations have gotten bigger and longer and everything else, but it seems like that was a major step forward.
Absolutely. Those are still known as novel agents, and they came out around the turn of the century. And as I had mentioned, we really didn't have drugs. We had steroids and melphalan until that point. And now we had, even though I think it's a misnomer, they're considered targeted therapies. We don't know what the target is, and I think their success is actually based on the fact that they affect many different things, like immune modulators affect angiogenesis and proliferation and apoptosis and sort of whatever item you test, they affected, and that leads to their success. And when they first came on, it was one of the big debates when I was starting is which one should you use first and then the other. And in 2019, I would say the standard is to use them together because we now have a second generation. The concern back then is like, okay, if I use this one drug, we know it's a finite span until the disease relapses, and you always want to have something in your pocket to use next. And so now that we can use them together, we still have something else to use next. We were having, not by themselves, but in combinations with steroids, these drugs had response rates that were comparable to melphalan without all the toxicity. Some of the toxicities we do think about with the immune modulators is an increased risk of thrombosis and blood clots, which we have since learned to mitigate with something as simple as a baby aspirin in the appropriate patient. And the biggest drawback of the first proteasome inhibitor, you mentioned bortezomib, we now have second and third generation, is limiting peripheral neuropathy. And so the newer agents really don't have that as their toxicity profile. So we've just outgrown it as another measure of success in the field.
So a patient diagnosed today with myeloma, what are, and now it seems like all patients get combinations. So, and I know there's not one size fits all, certainly, and some of this is kind of science and medicine based, and some of it is personal preferences. Kind of describe to us a couple of kind of patient profiles and what you think of or what most patients will hear about from their doctor in general types of therapies that they might receive.
So the great situation we're in where we have so many options and they're all good options is very frustrating for a lot of the community physicians because that's one of the most frequent calls that I get. It's like, how do I pick? Just tell me which one. Just pick one. From someone who only sees myeloma, it's just such a privilege to be able to then type and select the therapy for the person in the room. So some variables you take into account is myeloma specific, right? Is this someone who was incidentally noted on some pre-op labs, never even knew they had anything, and have no urgency to their care versus someone who came into the emergency room in renal failure and is starting dialysis? So the timing and how fast you need to start the therapy and how fast you need a response go into that decision. The cytogenetics, as I mentioned before, and other factors that we have in risk stratification. So how much of the marrow is involved. Again, different centers have different tests. Some of them are very good data, but they're not universally available, so it's harder to use their utility. So certain of the cytogenetic things will respond better to a drug class or another, so that would inform the decision. Then you can focus on the patient. You know, some 50-year-old a professional in Manhattan doesn't have time to come into the office, I may have an alternative that is entirely oral and doesn't require as many visits. Or someone who is elderly and wheelchair bound and has a difficult time coming to the office can be taken into account, or someone who is diabetic or has other comorbidities, other medications that might interfere with one or the other. And lastly, the toxicity of certain side effects. We have drugs that can be cardiotoxic, so you'll avoid that in someone who has a cardiac history versus avoiding a neuropathy-causing drug in someone who already has diabetic neuropathy. So you can put all of that into one giant bundle and pick just the right triplet.
So it sounds like for someone who focuses in myeloma, it's not a one-size-fits-all issue by any stretch, and you could easily see 10 new patients in a row and treat all 10 different ways based on their features, based on their myeloma, their tumors, and so on. So it's a lot to keep track. It's a lot to keep track of as well. So I want to, before we move on to some of the newer treatments and what you're excited about, there seems to have been a lot happening in the areas of MGUS, or monoclonal gammopathy of uncertain significance, and smoldering myeloma. These are kind of early conditions or pre-myeloma in some people types of conditions. First of all, what are those? Because there are obviously a lot of people that have those that either will or won't get myeloma and may or may not need an intervention. And if the approach to that changes, it seems like that could be something that has a big impact for a large number of patients.
Agreed. And that's another huge point. So I would say we have tremendous success in a newly diagnosed patient. So a newly diagnosed patient with myeloma has a certain amount of plasma cells that are abnormal in their bone marrow. They're producing an abnormal antibody in their blood, and there's some end organ damage. That was the classic definition of myeloma. They require treatment. Before they get to that, there is, you may have the proteins and the cells, but no damage. That is categorized under smoldering myeloma. And MGUS is the very, very beginning, where you just have some abnormal cells and some low-level protein. Interestingly, everyone's first question is, how did this happen? Where does this come from? And we don't really know, but there is a clear association with age. So the average patient with myeloma is diagnosed at age 69. If we were to take an entire population of the United States and send SPEPs looking for this abnormal antibody in all Americans, 5 to 10% of the population at that age would have an abnormal protein. So before everyone runs off and asks to have it looked at, the reason we don't recommend doing that is that 99 of them will never become clinically significant. So the diagnosis of MGUS ends in undetermined significance. The protein's there. We don't really know if it will ever bother you. The reason we don't ignore it is that 1% of them will go on to develop something clinically significant. So I think MGUS is good and myeloma is good. The smoldering myeloma is a much more heterogeneous group. So by definition, in the bone marrow, anywhere from 10 to 60%. So you can imagine it's a very different patient with 10% versus 60% involvement. So there was a category known as ultra high risk smoldering that is now a disease biomarker, and we do recommend treatment for those patients. Mm-hmm. So if you were at risk, we do now treat, and that line is moving earlier and earlier. So there were a number of clinical trials presented at the last ASH meeting actually using these 3 drug combinations, so a full therapeutic endeavor in smoldering myeloma to try to prevent the patients from ever having end organ damage. Long-term results are still pending on that. The most exciting part about those studies is the vast correlatives. So hopefully we'll be able to identify which patients, again, separate the bins and treat only those who really need it.
So this kind of fits the classic screening challenge paradigm, where you find people with earlier or precursor disease. Maybe that's a big question mark there. You could treat them aggressively or differently and prevent that disease from getting bad or causing big problems. On the other hand, you're treating a lot of people who aren't going to get the bad disease, and the toxicity, expense, anxiety is a big part of it. So it sounds like in myeloma you have your own version of that scenario here.
Exactly.
Yeah. So one area of treatment for cancers, and being a lymphoma doctor myself, we've had antibody treatments for over 20 years, and now myeloma has an antibody treatment. Tell us about that a little bit and how that's changed things.
Yes, we definitely had a lot of lymphoma envy for those many decades. Our first monoclonal antibody and second were both approved in 2015, so it's fairly recent to us. But very game-changing. I think monoclonal antibodies can be combined with other therapies in ways that you can't necessarily cumulative just put drugs together for the overlapping toxicity. So daratumumab, I think, is the one that has most excitement. It's a monoclonal antibody that targets CD38, and it had single-agent activity upwards of 30%, which is pretty much unheard of. Nothing else in myeloma had done that. And this was in the relapse refractory setting. So a very encouraging monotherapy, and it has now had 4 other approvals with different combinations in the relapse setting and most recently in the upfront setting.
And so that is really, I guess, improve response rates, duration of response. What's been are people living longer? What's kind of the big impact of that?
So it's very hard to tease apart because there were 4 drugs approved in 2015. Again, the field continues to change. Survival is doubling. You know, in 2000, you would have been quoted a 3-year survival. Side note on the internet, there's a lot of things that are still from back then that have these erroneous numbers. Now, for the average patient, if I had to pick a number, I would say 10 to 12. But again, there's a big confidence interval on the high risk versus low risk patient and all these different variables that go into this. But a lot of times when we try to generate that number, we're talking about a median survival from a clinical trial. And there's a line on the graph that is just never reached. You know, our patients continue to live on longer and longer. And so each year that goes by, the survival is 1 year longer, which is a really good problem to have.
So are stem cell transplants going away in myeloma, or not, or maybe, or time will tell? I
think it will be a long time. I would very much like to see a day where I didn't have to put patients through transplants, because I do those very personally. Every time we try to compare it, it is hard to make the transplant go away. The biggest study that was supposed to answer that question for us was an RVD followed by transplant versus continuous RVD with a delayed transplant. And again, the divided field, there was a great progression-free survival benefit, but no overall survival benefit. So depending on which way you wanted to read the data, you quote one number versus the other. So it is still a very effective way of getting patients into a deep and durable remission. It's just not changing the overall survival. So I think it has its place. And again, there are certain patients that are very alkylator sensitive and definitely will benefit from it, and others that don't get to that place. As a general rule for a newly diagnosed patient, if I can, I would like to get them to what we call an MRD negative state, which is the deepest remission I am able to detect in 2019. And the other data that came out of that clinical trial was that patients who reached that MRD negative state did have a survival benefit. And so I don't know that I can recommend it. It's not ready for prime time. It's definitely advised to be used in every clinical trial so that we learn about this minimal residual detection. As we have new tools, that depth of response keeps getting deeper and deeper, and it's a moving target. So while myeloma is considered incurable, it is highly treatable, and it's treatable to a deeper and deeper state every time we have a tool to find it at that 1 in a million, 1 in 10 million state.
So this concept of MRD, or minimal residual disease, is one that's very common in blood cancers and hematologic malignancies, making its way a little bit into some other areas as well in cancer. But this concept that we have these sophisticated tools, whether they're flow cytometry, whether they're molecular testing, whether they're combinations, and, getting the patient's amount of disease to a level that we can't see anything or that it is below the threshold of detection. It seems like in every disease we can think of, the group of people that are MRD negative, meaning don't have detectable disease or have low levels of disease, do better than those that are MRD positive or do have detectable disease. And that's intuitive. I guess the question is, do we change treatment on that basis? And I think in many different blood cancers, the idea of, well, you're an MRD negative patient, which is good. Can we give you less therapy or different therapy? If you're an MRD positive patient, do we give you more therapy? Which therapy? Is that basically the state of where you are in myeloma, or are there any other nuances there where that are kind of a big myeloma question in the field?
Yeah, so I don't know that myeloma is different from any other disease. One of the big arguments is, are you MRD negative because you had a nicer disease to begin with and you were going to get there no matter what?
Right.
So once you get there, can we leave you alone? And the counter argument's like, no, the person who can get there is the one who could potentially be cured, and you should continue to treat. So for now, there is not a clear idea of what to do with that information. In general, I just try to get them there. So it is my personal practice to change therapy if I can't get them there. And for example, in the timing of transplant, if an autologous transplant is going to be part of the therapy, should it be used up front or later? I think if you attain an MRD negative CR with an induction, you may not need the stem cells.
So in the rest of our time, I want to focus on kind of new drugs and new agents. And I know a big focus of you and your group is research and clinical trials. What are the 2 or 3 or 4 kind of exciting new drugs or categories of drugs that patients with myeloma or interested in the field should be paying attention to, because it's possible that in the near term or medium term they could be entering standards of practice, or at least have the possibility of making a difference for patients?
Yeah, so there are so many things happening in the field,
Sure.
as has been the case in the last decade. If I had to pick a couple, I think the 2 drugs that are sort of next in line for approval, one would be selinexor, which again is a completely novel mechanism of action that we haven't gotten to see in myeloma. It is a nuclear transport inhibitor, and so it's completely different, and it is being tested in a number of different diseases. The biggest important thing is that the patients who were studied in the monotherapy were what we call pentarefractory. So these are the patients that you would say you've had all of the drugs that we have as standard of care and there's nothing else. There's still a response rate with selinexor. So something that can salvage patients who've had everything else, with the caveat that there does seem to be quite a bit of toxicity and we're still learning how to mitigate that. So tempered enthusiasm. And the next one is venetoclax, which is approved for other disease states and lymphomas, but in myeloma, not there yet. As I mentioned, we have the cytogenetics to help classify the patients. The most interesting thing with venetoclax is an exceedingly high response rate, specifically in the group who have a translocation 1114. So it kind of moves us towards this field of tailoring treatment to a patient's specific disease state. So move us into that field. And both of these drugs do seem to combine fairly well with others. So it would most likely continue to be used in combination. The more exciting field is obviously immunotherapy. I think the number of patients who bring me in New York Times articles and other news clippings kind of points to the attention that is getting. And just like with so many other things, myeloma is a little bit behind. We've got a little lymphoma envy on the CAR T programs, because it took us a while to find a target that will treat the myeloma and not take down other cells or have undue toxicity. I think BCMA provides us that target. It is definitely the one that's moving ahead the fastest. We have monoclonal antibodies targeting BCMA, the BiTEs, and the CAR T. So different mechanisms targeting what maybe will be our new target. We also have CAR Ts targeting other things such as CD38 and The other antigenists are much further down. The BCMA CAR T, I think, will be up and coming in the next year or two, which is very exciting. Again, nearly 100% response rate was very exciting. As we start to get time away from the original studies, we see they're not as durable as we would have liked. It is great because it's kind of a one and done at the moment. We used to sell transplants as do this and then you can be off therapy. Now you require maintenance. Right now we do CAR T cells without maintenance, but we're still learning how to use them. So there may be different targets, there may be different constructs that allow us to modulate the toxicities, learning to mitigate the cytokine release syndrome and all of these things. I think with experience, they will become a less prominent part of the therapy. And I briefly mentioned the BiTEs, which are bispecific antibodies, and these are small molecules. So whereas the CAR T, as the name implies, is an actual cell with a receptor on it, the BiTE is just a small floating receptor that will put the tumor and T cell together. So the theory is similar in activating your own immune system to attack the cancer, and the toxicities happen to be similar as well.
So I want to end with just your thoughts on, you work in a myeloma center where there are people that have different expertise that they bring to bear on the many different problems and challenges and complications that myeloma patients can have. That seems to me to be particularly important in myeloma, given the complexity. And maybe if you could just take a second and, why is that so important for patients with myeloma in particular, and kind of what's some of the expertise that the center here and elsewhere, brings to bear when you have such a critical mass of people who are so focused on treatment and management of patients with myeloma?
Yes. So as patients live longer and longer, just the population of patients with myeloma is exceedingly large. I think one of my patients said it best when she says, I have shared custody with her local oncologist, and most patients with myeloma would benefit if they're not near a myeloma center and are being treated locally to at least have an expert at a myeloma center give an opinion, consult, get to know their case to help tweak these small details. Unfortunately, with these new drugs coming out, I have community physicians who are either very reluctant to take on a new drug, or on the other hand, who are very excited to use it and don't necessarily, get familiar with the preventable toxicities. And so knowing which reagents, what schedule to use them on, and what prophylactic to use is very useful. At our center, our nurses, our secretaries, our medical technicians, all they do is myeloma, and extrapolate that to our pathologists and our nuclear medicine partners. So it's very nice to have the finesse to pick up on very small variations and to focus on the supportive care. I think I mentioned at the beginning, one of the biggest things is the quality of life of patients is really remarkably transformed in the past decade. With things like bisphosphonates and now rank ligand to keep their bones strong, aggressive use of growth factors, which, again, if you treat other diseases, maybe it's contraindicated. In myeloma, we're very liberal with giving growth factor and chemo at the same time, and other small nuances, avoiding things like Advil, which most patients with pain would like to take some, can be very toxic to our patients' kidneys.
So it sounds like there's not only a lot changing and a lot happening, but really patients with myeloma and the complexities of this disease really require people that can be attentive to all these details, and obviously also know the new things that are coming along and can apply them the best. So this has been a great discussion. I want to thank you for joining us today. I want to also thank our audience for listening in. And I would like to invite you to download, subscribe, rate, and review CancerCast on Apple Podcasts, Google Play Music, or online at wowcornell.org. We also encourage you to write to us at cancercast@med.cornell.edu with questions, comments, and topics you'd like to see us cover more in depth in the future. That's it for CancerCast. Conversations about new developments in medicine, cancer care, and research. I'm Dr. John Leonard. Thanks for tuning in.
Cancer and cancer treatment can be very hard on the body. Rehabilitation medicine can help cancer patients recover from swollen joints, surgery, and other painful side effects. Be sure to listen to Back to Health, our rehabilitation medicine podcast featuring conversations with leading specialists about rehab, the latest research, and innovations.
All information contained in this podcast is intended for informational and educational purposes. The information is not intended nor suited to be a replacement or substitute for professional medical treatment or for professional medical advice relative to a specific medical question or condition. We urge you to always seek the advice of your physician or medical professional with respect to your medical condition or questions. Weill Cornell Medicine makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information featured in this podcast, and any reliance on such information is done at your own risk. Participants may have consulting, equity, board membership, or other relationships with pharmaceutical, biotech, or device companies unrelated to their role in this podcast. No payments have been made by any company to endorse any treatments, devices, or procedures, and Weill Cornell Medicine does not endorse, approve, or recommend any product, service, or entity mentioned in this podcast. Opinions expressed in this podcast are those of the speaker and do not represent the perspectives of Weill Cornell Medicine as an institution.